Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. All right, my favorite learners, today's episode is especially meaningful to me because we're joined by someone who's not only an expert in the field of neuromuscular blockade pharmacology, but also a personal mentor and role model. Today, we're talking all things neuromuscular blockade, from the pharmacology of paralytics to the evolution of reversal agents like sugammadex. And guiding us through this is none other than Dr. Sarah Giron, PhD, CRNA, and Program Director at the Kaiser Permanente School of Anesthesia. Dr. Giron was directly involved in the Phase 3 clinical trials of sugammadex and brings firsthand insight into one of the most revolutionary shifts in anesthesia practice. But beyond the research and credentials, she's someone I deeply admire. Her patience, kindness, and dedication to teaching are qualities that I aspire to embody in my own role as an educator. So whether you're a first-year SRNA or a seasoned clinician brushing up on pharmacology, you're in for a treat. Let's get into it. Well, my favorite learners, we are so excited this morning. We are talking about neuromuscular pharmacology with Dr. Sarah Giron, PhD, CRNA. Dr. Giron, we are so grateful for you being here and your expertise. So can you just kind of give us a little bit of background about you and how you got into education in the CRNA world?
Sure. Thanks, Dr. Gomez, for having me this morning. And, you're always doing such innovative things online. I'm thrilled to be here with you. So I'll start with my background. My first degree was in biochemistry and cellular biology from UC San Diego. I grew up in Chicago, and at the time, San Diego was probably the farthest I could get from the horrible weather of the Midwest. So I got myself out to the West Coast, and I got involved with research, obviously, that going hand in hand with biochemistry as an undergraduate. And I learned about nursing and nurse anesthesia when I took a part-time job as a GI tech in an endoscopy suite. And yeah, way back when I had to take that job for extra money for beer and gas in college, as I'm sure many of your listeners are well aware of, you need extra money. And it was really that side job that changed my life. I really loved how the nurses were with the patients. I loved, they were just with the patients so much more than the doctors were. And I loved how the nurses made the patients feel. And I loved seeing, all of the human interaction, I think, was much more attractive to me than the cold lab that I was working in at the time. So I finished at UC San Diego. I moved to New York City. That's where I did my bachelor's in nursing at Columbia University. I became a burn ICU nurse there. And then I decided to just keep going with nurse anesthesia because why not? Anesthesia was challenging. It involved a lot of the pharmacology, which was, hard stuff for me at least. And at the time I was young and I wanted a challenge, and anesthesia really married, I think, the hard science of my previous degree with the nursing that I really, really enjoyed. So that's why I kept going. And my background in education, I was always the student asking, why does this happen? Or how does this work? And I had friends who were really content memorizing facts and were really brilliant. And they could read things once, I think, and immediately just grasp the concepts. And I really couldn't do that. I had to break things down into steps and write things out or draw out processes on a whiteboard. I had many whiteboards so that I could understand the topics. And it was much more labor intensive. It was definitely a much more labor intensive learning process, but it worked for me. And I think I found my learning process really helped when someone would need help on a topic, or if I was orienting someone on the unit, I could break something down into manageable bite-sized portions. And speaking of the unit, I think my managers and supervisors also noticed that I was much more patient with learners than others. I didn't mind taking on a new graduate or a shadow or precepting an EMT student. So I was eventually voluntold that I should continue in the educator track. And I think at the time I was volunteered for quite a few things like, morning meeting lectures or grand round presentations. And pretty soon people just started telling me that I would be doing this professional project or that. So I kind of fell into this role with a little luck and a lot of whiteboard drawings and I guess a bit of genetics because both of my parents are teachers.
Nice. I didn't know your parents were teachers. That's very cool.
Yeah,
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 I feel like a lot of us in education, like we don't set out to do education. And it's kind of interesting to hear you say that because that was my experience as well, that like it just kind of fell in
yeah,
my lap and I loved it and just kept going with it. And I always tell
yeah,
people we need educators with that patience and with the heart to do it because not
yeah,
it's not for everybody, but I'm so grateful for
right.
you and people like you that encourage students to learn in a different way or in a visual way with the whiteboards, which is so cute.
And
Um,
likewise.
Thank you. So we're going to dive into the first topic, which is neuromuscular blockade. So we're going to talk about the basics. So can you kind of explain the mechanism of action between our depolarizing neuromuscular blockers and our non-depolarizing neuromuscular blockers?
Yeah, of course. So we have two different types of neuromuscular blockers or paralytics or relaxers. I use those synonymously in lecture. Of course, I always tell students definitely don't, tell a patient we're going to paralyze you. Like, no, so neuromuscular blockers or paralytics or relaxers. We use a lot of different types of those intraoperatively. And one class of them, the depolarizing paralytic class, only has one medication that's like really easy for us to remember. That muscle relaxant is succinylcholine or nectine, as it was called way back in the day, if you remember that. Succinylcholine mimics the neurotransmitter acetylcholine at the junction where the nerve meets the skeletal muscle. And by mimicking acetylcholine at that neuromuscular junction, when succinylcholine binds to the receptors in that skeletal muscle, the muscle contracts. And since we're giving quite a bit of succinylcholine for the placement of, say, an endotracheal tube in anesthesia, the muscles massively contract, and then they have to relax and recharge. And it's that short period of time when the muscle is relaxing and recharging that we get a nice brief period of paralysis. The other class of neuromuscular blocker we use in anesthesia is the non-depolarizing class, and that works competitively by blocking the same receptors at that neuromuscular junction. And if a non-depolarizer paralytic agent is administered to a patient, it attaches to those receptors in the neuromuscular junction. The neurotransmitter acetylcholine cannot bind to that receptor. Acetylcholine is basically looking for an open receptor, and all the parking spots on the receptors are taken up by that non-depolarizer. So the muscle can't contract because acetylcholine can never find a parking space. And then skeletal muscles obviously need that acetylcholine to contract. And if the muscle can't contract, obviously then it's paralyzed for a period of time that's unique to the non-depolarizing agent that's attached to the receptor.
It's beautiful, beautiful summary.
I'm
I
trying to keep it as simple as possible.
This is great. It's perfect. I think the listeners will definitely appreciate that. And I like the analogy of the parking spot because,
Yeah.
yeah, it's so the analogy that I've kind of come up with is that the receptor is like the light switch. And for
Mhm.
acetylcholine, it's stuck on. So it's continuously depolarized until you reset the electricity and it can, again, not be.
Love it.
And then the other one is like a piece of tape over, like again, the parking spots are all taken up. There's tape over all of the light switches. So
Yeah.
kind of like it's nice to make those connections to things that we already can
Mhm.
kind of conceptualize. So I like the parking spot. So I might switch over to the parking spot analogy. We'll see.
Totally fine. It is free for all.
So you kind of touched on it, but like, how do those mechanisms translate into clinical onset and duration, and how do we kind of use them intraoperatively?
So that's a great question. And um, so since the depolarizing agent, succinylcholine's action is dependent on how fast the muscles can like recharge from those massive contractions, clinically, you really only realize paralysis in a patient for usually less than like 10 minutes. For non-depolarizers, those agents have to leave their parking spots on the neuromuscular junction receptors, and each agent has its own unique amount of time that it likes to hang out parked on the receptor. So we get varying amounts of paralysis time. And of course, this is an extremely watered down version of the mechanisms of action. Certainly patient factors, hemodynamics, the comorbidities of the patient all impact how fast these agents work and when they wear off. but at least it's a start. And I think we'll talk in the future about kind of the concentration gradients that do pull things off of the receptors. So yeah.
I love that. That's perfect. So the next part we're going to talk about is reversal. So how do you approach the use of neostigmine versus sugammadex in your own clinical practice?
So yeah, so neostigmine versus sugammadex. It's no surprise that if we're going to relax our patients intraoperatively, we definitely need to reverse that paralysis if the surgery is complete, and we obviously want to either start the next case, but we certainly want to wake our patients up. And after all, we want those patients to wake up from surgery feeling nice and strong, right? Because if you woke up from surgery feeling weak or not being able to breathe, that would probably be terrifying, I would say, right? Eek. So there's clear indications for which reversal drug works with the various neuromuscular blocking agents, and the easiest to remember, obviously, is that succinylcholine does not need to be reversed. It wears off on its own. Neostigmine is one of the reversal agents, and that can be given to reverse non-depolarizing agents like rocuronium, vecuronium, cisatracurium. Those agents are all probably the most frequently used non-depolarizers in clinical practice these days, I think. The caveat with neostigmine is that you have to give it with glycopyrrolate because of all the I'm going to see if I can get this out of my mouth this early. Parasympathomimetic side effects. And so it has some bad side effects. That's why we give glycopyrrolate. And it can only reverse mild to moderate levels of relaxation or paralysis that is induced with a non-depolarizing muscle relaxant. And it takes a bit longer to reverse paralysis compared to sugammadex. So the timing of this reversal is drastically different than when someone uses sugammadex. As you know, since you teach this topic, neostigmine is a drug that belongs to a class of drugs known as anticholinesterases. Cholinesterase is a naturally occurring enzyme in our body that breaks down the neurotransmitter acetylcholine at that neuromuscular junction. Neostigmine prevents the enzyme from breaking down acetylcholine, and that's why it is an the enzyme cholinesterase. So it's an anticholinesterase. So if the enzyme doesn't break down acetylcholine can start building up in the neuromuscular junction, and if there's a higher concentration of acetylcholine in the neuromuscular junction, there becomes a concentration gradient that is, in essence, what it does is it fosters that non-depolarizing muscle relaxant to come off the receptor or back out of its parking space. And if the non-depolarizer backs out of its parking space, the muscle can now attach to acetylcholine. And if it can attach to acetylcholine and acetylcholine has a parking space, that muscle can contract again. And then, thus, the skeletal muscle is no longer paralyzed. Now, with the reversal agent sugammadex, the main caveat is that this reversal drug can only reverse certain non-depolarizing drugs. So sugammadex can only reverse the paralytics rocuronium and vecuronium, but it can do so at any level of paralysis, deep, mild, moderate. If the CRNA used rocuronium or vecuronium, sugammadex can reverse it. So because sugammadex isn't working on an intrinsic enzyme like cholinesterase, and it's not working on a physiologic receptor, there are fewer side effects, which make that reversal drug, sugammadex, a great option to reverse ROC or VEC-induced paralysis. However, you do have to monitor the level of paralysis with sugammadex because the dosing of sugammadex is done by the degree of paralysis or how paralyzed or relaxed the patient is. Now, sugammadex does have its side effects too, but less so, I would say, than neostigmine. It can be expensive, which may limit its availability to some anesthesia practitioners, and it's contraindicated in renal failure patients. So there are some limitations to who could receive sugammadex and who's able to use it. Sugammadex, I can keep going. Sugammadex is known as a selective relaxant binding agent. I'm amazed I can get that out in the morning. So that's the class of drug it fits into, and its molecular shape looks a lot like a donut. And really what it does is sugammadex's donut encapsulates ROC or rocuronium or vecuronium molecules in the neuromuscular junction. And if there's less rocuronium or vecuronium in the neuromuscular junction, again, that concentration gradient is going to cause the agent that's on the receptor to come off or back out of its parking space. And obviously, when the non-default polarizer, ROC or VEC, comes off the receptor, backs out, then that receptor can now bind to acetylcholine, the skeletal muscle can contract again, and paralysis is reversed. Voila.
Best.
Clinically, I think I'm probably one of the only CRNAs that still uses cisatracurium for liver and renal failure patients. So I obviously use neostigmine to reverse paralysis of those patients that receive cisatracurium. For patients where rocuronium and sugammadex reversal is not contraindicated, I'm fortunate enough to practice in a great place at Kaiser Permanente South Bay where we have access to sugammadex. So I definitely use sugammadex.
I love that you talked about the cost of it because I looked up the cost because I was curious because it is expensive.
Yeah.
It's a lot of the barrier to practice change in using sugammadex. So one study that I found said that it's an additional $77 per patient with sugammadex, but a net savings of $502 when factoring in reduction of OR and PACU time. So that's kind of
Yeah,
interesting. That's an argument for its use, even though it's expensive.
absolutely.
But it's interesting because
I'm so
when
glad you found that.
it's yeah, I love the
It's a
numbers.
good, that's a,
It
yeah.
just makes sense to see the cost saving when you think about OR and packing
Mhm.
time, because we know OR minutes are very expensive.
Very expensive. It's wild.
Yeah, another
Yeah.
thing was that you mentioned that brought up some memories for me is that when I graduated in 2016, sugammadex was like brand new. I think it was
Mhm.
one of Dr. Nagelhout's like final pharmacology lectures to us was just
Oh.
introducing what sugammadex was and like, oh, you
Mhm.
may see this soon and it's the up and coming type of thing. But I think that there's such a technique to using. I'm glad to hear that you still use neostigmine and glycopyrrolate because it's such a skill to use and to be able to
Yeah.
clearly see the weakness and that paradoxical breathing that comes with weakness when patients are weak before extubation, hopefully not after.
Yeah.
Kind of tune into those things because sugammadex is such a beautiful drug that you don't really have to think about all of those sequelae with weakness.
No.
Yeah.
No, and I wonder about a lot of the folks we're educating, Dr. Gomez, like how many of them will even know that because I'm sure there'll be additional drugs that come out. I mean, it's wild what we saw and what we, used to practice with and what they will and
Or even
it's just so much safer.
yeah, it's much safer. And I just remember even being in my pediatric rotation at CHLA and
Yeah.
we did a baby. I don't even remember the procedure that we did. And I had my neostigmine and my glycopyrrolate pulled up in TB syringes and I was
Yeah.
people checking and there's the side effects are pretty, significant. So giving the glycopyrrolate, watching the heart rate come up before you give the neostigmine. I mean, there's just a skill
Yeah.
and a technique to it, especially with tiny
Totally.
babies in TB syringes. I was like, this is a lot. So it's nice that we have sugammadex now, even though it's kind of not used as frequently in pediatrics. It's starting to be
Right.
used in pediatrics,
Yeah.
but um,
Yeah.
so thank you for all of your insight. You were directly involved with the clinical trials for sugammadex. So
Yeah.
what did you learn from that experience? It's so interesting. And how has it shaped your opinion on neuromuscular blockade reversal?
So yes, so you kind of mentioned sugammadex wasn't FDA approved in the United States until the end of 2015. The EU had been using it since 2008, I think, but it took the US a little longer to approve it, and we really only had it in practice for about 10 years now. And I was fortunate enough to be part of the sugammadex clinical trials at UCLA. I was practicing at UCLA at the time. And again, maybe I voiced a little interest in helping with those phase 3 trials. And given I had a history of research, I was very quickly voluntold again. I would be helping coordinate the cases where sugammadex would be trialed. And way back before it was approved, it was known as Organon 25969 or ORG 25969. And so it was the first time I ever got to use a quantitative neuromuscular blockade monitor was during those clinical trials. And, that was fascinating to me. We just, had qualitative monitors at the time. But, at the time, given what we were just talking about, giving sugammadex was really revolutionary. I mean, we didn't have to time our reversal of paralysis 15, 30 minutes out from the end of the case like you have to do with neostigmine. Sugammadex could reverse paralysis in like 2 to 3 minutes, which was just wild. And the reversal was complete. The patients were strong. They were ready to go to the PACU. And it, I think, really required anesthesia providers to completely relearn how to wake up a patient at the end of the case. Just because of that timing, it really changed the art of waking a patient up. And as far as how it shaped my perspective on neuromuscular reversal, I personally think that sugammadex has its advantages and disadvantages. So the major advantage to sugammadex is that, as we were talking about, it really increases patient safety. So no longer are patients weak in the PACU. The negative experiences, I think of not feeling like a patient could breathe. In the recovery room, that's mitigated by really that fast, complete reversal with sugammadex. And I think it gave anesthesia providers options, which is nice because how they manage cases that really, in cases where paralysis is only needed for brief periods, or if an anesthesia provider found themselves with a patient's airway that they couldn't intubate, you have fast, reliable reversal, even of deep paralysis. And I think that revolutionized anesthesia management and increased patient safety. I think another advantage of the drug is that it, hopefully encouraged more of our anesthesia colleagues to use neuromuscular blockade monitoring, because really the dose of sugammadex that is given to a patient to reverse paralysis is based on the level of paralysis. So the drug really did enforce that practitioners monitor the train of 4 or post-tetanic count to dose their neuromuscular reversal. And again, I think it's another great way that hopefully sugammadex increased patient safety. Unfortunately, I am going to also say that I think there's disadvantages with sugammadex. And I think one of them being that, I feel that the ability and the availability of the agent really has taken away from the art of anesthesia in some regards. There are some practitioners now that do not time their paralysis to the end of the surgical case and are perhaps a little bit more heavy-handed with administering large amounts of rocuronium or vecuronium intraoperatively because they know they can reverse any level of paralysis. So they give larger doses of a paralytic than they would have normally. Or if they had to reverse with neostigmine. And I don't know if that cavalier way of practicing is great. I think we should be titrating our drugs based on the length of the surgical case and using, the least amount of pharmacotherapeutics to reverse our relaxation. For instance, most practitioners I know don't give like 20 milligrams of midazolam at the beginning of the case and then reverse the patient at the end with a large dose of flumazenil. The same should be the case with reversal with sugammadex. One other thing I'll say is that, I feel, unfortunately, this is another disadvantage of sugammadex. I feel that some practitioners have gotten so used to reversing with sugammadex that they kind of bend the rules on what patient this reversal is appropriate for. I know there are practitioners out there that do use the drug in renal failure patients, and that's really against the manufacturer recommended use of the drug and how the drug was approved by the FDA. Anytime a practitioner uses a drug in an off-label capacity, I think that's just asking for litigation and, as I call, clinical signs of badness to happen with your patients. So that's probably another disadvantage.
Clinical signs of badness. I like that.
Clinical signs of badness, yeah.
Very true. Yeah, and I do agree. It takes away some of that vigilance that we're so, it's ingrained in us to do, and it just takes away a little bit of that. I totally agree with you. And I loved how you mentioned about the 20 milligrams of midazolam. It's so true. We never overdose a drug and then just reverse it at the end of the case. This is the only case where we do that when we have to, and not because, any other reason. So the next question I have is about neuromuscular monitoring. So I'm going to kind of alter the question that I had for you a little bit because you mentioned qualitative versus quantitative neuromuscular monitoring. Can you kind of describe the differences between the two to our listeners and your experience in the clinical trials and using it?
Yeah, great. So, and it's wonderful that you ask about monitoring because I really do feel that this is such a patient safety issue. So you have two types of monitoring for neuromuscular blockade and how relaxed or paralyzed a patient is intraoperatively. You have qualitative, which is your normal run-of-the-mill twitch monitor that you can do train of four, the four twitches. You can do post-tetanic count. You can do single twitch, tetany. Those are the types of qualitative twitches that you elicit at a nerve to see a muscle move. And it's really up to the practitioner to actually look and assess the twitches. So you're going by your sight, you can feel when you do that, but it's really based on the practitioner. Now, a quantitative monitor actually has a unique, and every manufacturer is different, but a unique way that that actual monitor will calculate the ratio of the first to the fourth twitch, giving you a ratio of the train of four twitches, which is great because if you have a quantitative monitor, it really takes out that guesswork or that subjective clinical part of us just looking or feeling and really trying to assess how much of a fade you have with your monitor. Now, I think for me, getting to your question about this type of monitoring and the clinical trials I was part of, it was the first time I had ever seen a quantitative monitor used, and it was I can't remember the manufacturer we used for the study, but it actually was, we did it at the adductor pollicis and the ulnar nerve. And it had an apparatus between the thumb and the pointer, which actually calculated the train of four ratio, which if you have a train of four ratio greater than 0.9 or 90%, you can be very well assured that the patient is fully reversed. And what's funny is I remember when I was in school, I graduated in 2005, a train of four ratio of 0.7 was actually considered okay. And they found out, that that's not the case. So the current standard is that they want much less fade in between those first and fourth twitches, which I love because it obviously ensures much more safety. So that was the first time I ever was able to use that. And I think for our novice students or novice practitioners, anytime you can get your hands on a quantitative monitor to get that train of four ratio, that's how I prefer to do monitoring for neuromuscular blockade. However, not all facilities have quantitative monitors. It's also case specific. If the arms are tucked, you really have to use a different type of quantitative monitor to actually get the thumbs to twitch, and it doesn't work well on facial muscles. So there are, again, advantages and disadvantages to quantitative monitors. Always, I will definitely use, if I have available to me, a qualitative monitor, because most facilities have those, right? If I do have a qualitative monitor, I always check train of four. If there's no train of four, I go to the post-tetanic counts. And of course, at the end of the case, if I only have a qualitative monitor and I can see that my patient has a train of 4 out of 4 twitches and a sustained tetany of greater than 5 seconds, I feel pretty good that my reversal is complete.
That's awesome. When I was a student, they had quantitative monitors at one facility. I think it was Riverside County or somewhere, where they were just trialing it. And then a CRNA that I worked with recently that graduated from Duke University used it quite frequently. They would use BIS monitors pretty frequently, and the quantitative monitors. Just discussing with her, I was like, what do you find with those things? Like using that throughout your training pretty consistently. And she was like, honestly, gives less agent because the BIS of less neuromuscular blockade, because it takes out that guesswork. It takes out that subjectivity. Like, I don't know how many times under the drape I've had a flashlight looking at the ocularis oculi, and I'm like, was that a twitch? Was that not a twitch? Like, you're kind of guessing with your flashlight under the drapes. Isn't it? So the quantitative is awesome when you can get it, like you said, because it takes out that guesswork. Yeah, it's pretty interesting to see. So yeah, if you're listening and can get your hands on one in a training facility, it's awesome to see. Yeah. So the next thing we're going to go into, we've kind of touched on it a little bit here and there, but when it comes to dosing, how do you tailor your neuromuscular blockade for various patient populations? Like you had mentioned, renal dysfunction or maybe obesity.
Sure. So as I said, I'm probably one of the few practitioners that still uses cisatracurium for renal failure patients. Depending on the level of renal impairment, I will consider other agents like rocuronium or vecuronium. And again, depending on the severity of the renal impairment and maybe the patient's potassium level, I do feel that there are emergent situations where succinylcholine could be considered for, say, an emergent bad airway in a renal patient, but it's all dependent on potassium, how bad is the renal impairment. So with obesity, I would say generally, I just remember that succinylcholine should be based on actual body weight. Our non-depolarizers are dosed on ideal body weight. And that's about the only dosage adjustment I make with obesity or obese patients, bariatric patients. For maintenance, though, I still practice where I monitor the patient with a neuromuscular twitch monitor and I titrate any redose very carefully. I usually start with 1 or 2 cc's of the agent I'm using, and then I time how long it takes for the patient to regain, say, a twitch or two. And then I adjust any subsequent doses or redoses based on that recovery time. So every patient's different, and I think that's one of the things that I highlight to my students. I know you probably do too, is just there isn't any cookie cutter cocktail version of anesthesia. We should all be looking at the various factors for these cases and then choosing agents and redosing them specific to the case and the patient.
Yeah, there's definitely not a recipe. That's what I always say. Like nothing is
No.
and it's very patient dependent. Um, So are there any specific red flags that you look for or watch for when using longer acting agents? It's kind of like for us at the facility I was working at, now I'm per diem, but we would do like VEC drips, like drips for our free flap cases. So we don't use that very frequently anymore. It is kind of like this rock, but have you had any experience with the longer acting agents and how do you kind of watch for red flags?
Yeah. So so for me, the really longer acting agents were like pancuronium. And I know nobody has seen pancuronium in clinical practice for years, and I certainly haven't either, but that was a great drug because, it would keep the patient's heart rate up. And if you weren't going to extubate the patient at the end of the case, pancuronium was a great drug. And I don't think anybody's using that long of an acting agent nowadays, just because procedures and surgeries have just gotten so much faster, better. Patients are expected to go home, at the end of cases. But as far as red flags that concern me about using like longer acting or more dosing neuromuscular blockade for longer procedures, I think I would be concerned if a colleague gave like a full 10 cc syringe of an agent at the beginning of a case where perhaps the surgeon could open up the patient and then have to abort the case because of an increased malignancy or inoperable conditions. Back in the day, if you did that, if they had to close the patient right back up, even though it was scheduled for a 12-hour tumor debulking or something, you wouldn't be able to reverse that type of paralysis. And now if you use rocuronium or vacuronium, you can certainly reverse it with sugammadex, but that would be kind of a red flag if you were just cavalier about pushing a whole syringe of something. I'd be concerned if a provider gave an inordinate amount of agent without checking twitches. Again, if that provider gave a big whopping dose of paralytic close to the end of the surgical case, that would be a little bit concerning. And I do honestly believe you should just give the right amount of anesthesia, not too much, not too little. I liken anesthesia to cooking. You want to make the dish taste good, but not too salty, not too spicy. And just because we have reversal agents for some of our drugs, like we have Narcan for narcotics, we have flumazenil for our benzos, that doesn't give us the right to overdose our patients, knowing we can reverse that overdose. I'm a big fan of monitoring the patient's depth of paralysis and then obviously titrating the redoses based on the length of the case and the need for additional paralysis.
I love that. What comes to mind for me with red flags when you were mentioning train of 4 monitoring is monitoring in between. If I take over for a case and a provider hasn't done a train of 4 in between administering acetylcholine and administering a non-depolarized.
Yeah,
Because at
great. Yeah,
the end of the case, you may have a pseudocholinesterase, very rare, but I
deficiency.
a
Yeah,
couple of cases where pseudocholinesterase
absolutely.
deficiency is in our differential diagnosis. And it's like, well, did they do a train of 4? When the question is, did I do a train of 4? I always do. I try to make sure before that dose that I have those twitches back from acetylcholine before I administer a non-depolarizer, just to make sure that I know I can knock that off of my differential if the patient's weak at the end of the case.
Yeah.
So that's something I do in my practice personally. But
Practice smarter, not harder.
Exactly. And it's all about patient monitoring, and I love how you're specific about that. So in terms of your approach to choosing a neuromuscular, you've kind of touched on this already, but we'll talk about it again, and reversal plan during the preoperative assessment. So what things, I guess we can kind of talk about acetylcholine as one, your pre-op, when you would use sucks, when you would not use sucks for intubation maybe, and then we can talk about the non-depolarizers as well.
Sure. Hey. Yes, definitely pre-op. Pre-op is where I think, a lot of our drug selection should be happening, right? And especially for neuromuscular blockade and reversal, it should be starting in pre-op when you're looking at the patient's history. And definitely, I always look at my patient's health history, their current lab findings. I tailor my anesthetic to them and their surgical procedure. If a patient has renal failure, like you said, I like to use cisatracurium. And definitely if it was an emergent case where I had to emergently place an endotracheal tube, I'd be looking to see what the potassium level is. Is it less than 5, milliequivalents per liter? What is the potassium level? How bad is that airway? Is the patient in full-blown end-stage renal failure, or is there creatinine clearance greater than 30, because then we're looking at a whole different type of renal impairment than, say, full-on end-stage renal disease. And again, those will help me tailor whether I'm going to go down the route of using succinylcholine or whether I should use rock, and then, if I can't intubate, then reverse with sugammadex. So there are those issues. If I was just approaching a patient in pre-op and the patient had renal liver failure, I would most likely go to cisatracurium. If that patient has a horrible airway or a case might require no paralytic, I like to use succinylcholine still. If the patient has obviously greater than 5 potassium, and that's for me. I know some people are a little bit more cautious with potassium. Maybe it's 4.5. What I've read in the literature shows it's okay to use succinylcholine if the potassium's 5 or less. Certainly, if they had a dibucane number, like you were talking about, if there was some little hint of like maybe a pseudocholinesterase deficiency or a muscular dystrophy, I would steer clear of succinylcholine. I had a friend in school who actually used succinylcholine on a patient that it was completely unknown that they had pseudocholinesterase deficiency, and they were completely homozygous pseudocholinesterase deficiency. It made for a great morning meeting discussion, but that patient, they used sucks at the beginning of the case, and the patient was still intubated when my friend and I left for that clinical rotation that day. The patient was still intubated, vented, because it takes a very long time for sucks to wear off if there's a full-blown pseudocholinesterase deficiency. Um, if the patient has a massively muscular build, I would consider using a defasciculating dose of a non-depolarizer before sucks. And there's also cases where I don't use neuromuscular blockade for intubation, and I know a lot of our students probably can't fathom that. It's certainly safer when you do use a paralytic because you're obviously not aiming for a moving target. There's less chance of any kind of damage, but an LTA in a non-paralyzed airway is a great tool for certain types of cases, and so there's just so many considerations. I mean, we could probably have coffee and discuss all of the different considerations for hours, but to get to the main point preoperatively with sugammadex, if a patient is a female of childbearing age that may be using hormonal contraceptives, I usually counsel them to use backup methods of contraception, regardless of whether I'm using sugammadex or not. And that's because, a lot of our antibiotics, uh, our different medications, anesthetic drugs, they all lower the efficacy of hormonal contraceptives. So it's great to mention to our ladies preoperatively that backup contraception is a must. It's not just unique to sugammadex, but a lot of the adjuvant drugs that we use and our anesthetics will impact their contraceptive. So, I mean, I would just counsel them no matter what.
I love that. I remember when they rolled out sugammadex at the facility I work at. I remember going to the recovery room and I was like, okay, I gave sugammadex, so we need to discuss with her once she wakes up before discharge, 7 days of backup methods of contraceptives or
Yeah.
whatever method. And they were like, what sugammadex? What, a week? And I was like, oh, we got to do some PACU education on this. So now they've rolled out a lot. And I think Kaiser students actually did a DNP project on educating, like having there be discharge instructions or something populated for the patients to be educated before they go home, because that could definitely be missed in the whole, because we're gone by the time the patient's alert and awake and go home. So that's definitely something maybe I should start discussing in pre-op, because you just never know when you're going to use it. It's not all the time, but you could use it. And if you do, that's definitely something that should be educated on. So I love that you mentioned
a great DNP project. Who had a great lead?
Oh, there we go.
Is that why you brought that up?
No, I didn't know
that was my group. Yeah.
Oh, that's so funny. No, and I loved it because I used it. I used that one. I did. Oh my gosh, informed consent for my DNP project and educating moms on post-dural puncture headache. So I really wanted to implement something similar, but my time frame was much shorter. So unfortunately, I didn't get to the PACU discharge portion of it. But I used yours. I didn't know it was you. So thank you for your example.
Yeah. And we actually, we also partnered with the EMR folks so that if sugammadex was given in the intra-op electrical record, like it actually triggered a note to be generated in their PACU discussions that get printed out and sent home with the patient by working with our HR Connect people. So
that's amazing. It's just a little thing.
Or not HR Connect, our, what is it? Health Connect, sorry.
Health Connect, yeah.
We have so many different connects at Kaiser.
And it helps patients in, like, you think it's such a small way, but you never know. And I'm like, you never know when the sugammadex babies generation is going to be here, because
sugammadex generation babies.
It's hard to link it back to the administration of sugammadex, but let's just make sure everyone is knowledgeable and aware of the medication and its what it does. So that's great. So what are some common mistakes that you've seen? I was trying to think about this personally, in new learners or students, or like just a clinical pearl that you think students can take with them into the clinical setting.
Sure. And I mentioned this to a lot of my students. I'm not going to just say it's students or new practitioners or any novice people. I'll give you an example of somebody that was a seasoned practitioner, and I tell my students this story all the time. But when I was a student and I was working with an attending in school, we were in the GI clinic, and I remember specifically that we had intubated the patient with sux or succinylcholine, and at the end of the case, she said, "Hey, have you reversed the paralytic?" And I was like, no, we only gave succinylcholine, remember? And I told her again and again, and probably 2 more times after that, I said, we only gave succinylcholine. And she said, you always reverse patients. You always have to reverse patients. And she gave the patient neostigmine and glycopyrrolate. And I remember just going to class the next week, almost in tears, and telling my friends, oh my gosh, I've really missed the boat, guys, because I really thought I got this paralytic pharmacology comprehension, but I really have missed the boat because I thought we weren't supposed to be reversing sux, and this attending told me we should, and needless to say, I'm not sure what that attending was talking about, but it was clear that she was definitely the one misinformed. We don't reverse succinylcholine, but to your point, I've seen a lot of novice people try to guess how much sugammadex to give because they didn't have a neuromuscular blocking monitor. And when I heard that, I quickly brought them a monitor. I've seen practitioners use no neuromuscular blocking or blockade monitor and base their extubation on these kind of, I don't know, they're like folklore things in anesthesia, like a tidal volume for 3 to 5 breaths is enough to gauge that they're ready to be extubated, like kind of odd things like that. So I've seen all sorts of kinds of odd behavior when it comes to neuromuscular blockade reversal. But I think probably the most common mistake are new learners and even new providers really. What their mistakes stem from is not knowing how long certain surgeons take for a procedure and miscalculating how much time is left for a procedure. And that's not the learner's fault. It's not that new practitioner's fault. I think, because I've seen laparoscopic cholecystectomies take 20 minutes skin to skin, and I've seen them take over 6 hours. And I think the grace and skill that our learners really idolize in us is due to the fact that we just know how much longer we have in a case, and therefore we're able to time the maintenance of our neuromuscular blocking drugs in that case accordingly. So our wake ups look better because we know how long the resident takes to close fascia compared to the attending surgeon, right? That grace, I think, just comes with time and practice and probably, knowing your surgical team.
Yeah, I know. I usually at the end of like once they become seniors, I'm like, okay, what do you want to work on? Like, what are your goals, for today? And they always say like, oh, I want to like time my wake ups better. And I'm always like, that's great, but like you're gonna get to another facility where you work, and like if it's not the facility we're working at, you will get to know your team. And because each team at each facility is so different. Some have med students that end up closing. I worked at a university medical center as a new grad, and that was a whole new learning process of like, oh, okay, then they're letting the med student close. It's going to take much longer. I'm like looking over the drape a little bit more frequently, but we all have to learn and start somewhere. But another thing that I like that you mentioned was that I mentioned to students too is the tool belt that they have, right? And like as they go throughout school, they'll see providers do things where they're like, oh, I'm going to do that. Oh, I'm never going to do that. And so I always tell students, even if it's like the thing with the reversing acetylcholine, like you see that and there's always something to learn and put in your tool belt, and you added that tool belt that day. And at the end, they have this belt of things that they practice and they can take into their clinical practice. So
and then that's their brand of anesthesia.
Exactly. And we all have our own art. That's what makes it the art of anesthesia. I love that you mentioned that. One thing that I ask all of our guests to do is to give one piece of encouragement or advice to, this is going to be the first or second quarter technically of my students that will be listening to this, but for any anesthesia learners at any point, what is one piece of advice that you have for them?
Just keep putting one foot in front of the other and, try your best to learn from your mistakes. I cannot even fathom doing nurse anesthesia training now with the addition of a DNP or a DNAP project. Our education is a marathon for sure. And as long as you just keep putting one foot in front of the other, you're going to get across that finish line. And I would just say, get across that finish line because we're going to be there with open arms to welcome you to just this wonderfully fantastic profession. So yeah, it's a marathon, not a sprint. Don't burn out. One foot in front of the other.
Totally agree. And the DNP portion of it, the 3 years, man, that's a long time. And just got to take it. If you look at it as 3 years, it'll be so overwhelming. You just have to take it piece by piece, day by day. Well, I thank you, Dr. Giron, for being here today and for all of your knowledge and wisdom. This just was incredible. So I appreciate you, and we all do. So thank you so much.
Thank you. Thank you.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.